So we spent the first, I don't even know what section we're on anymore, F. So we spent the first five sections of Chapter 8 talking about dynamic LV output as a response to changes in intrathoracic pressure as a marker in a very highly select group of patients as a marker for fluid responsiveness. So some people kind of call that the arterial side, or assaying the arterial side for dynamic changes to predict volume responsiveness. Whereas some people say the assessment of vena cava dilation and collapse is sort of like assessing the venous side for dynamic changes, a marker of volume responsiveness. And again, the same principles apply to the vena cava. That is, changes in the caliber of the vena cava were derived in a very specific patient population under very specific scenarios, and that with very consistent and regular changes in intrathoracic pressure as the stressor on the cardiovascular system. And when you try and extrapolate the data beyond those patient populations, you can start to run into a lot of problems. And I'm seeing this quite often in the ICU, and it's I think could be potentially dangerous because these pocket ultrasounds are so readily available, and people are looking at IVC collapse all the time. It's kind of easier to do that than try and calculate out pulse pressure variation. But that, as I'll talk about, again, these metrics in terms of IVC change and SVC change are only in very specific patient populations, and I think after you watch this section, you'll realize in whom you can apply this physiology, in which patient population you can apply this physiology. So there's a considerable amount of confusion regarding ultrasonographic evaluation of the vena cava. Some of this confusion is the result of interchanging central venous pressure or right atrial pressure with both volume status and volume responsiveness. And hopefully by now you realize that volume status is a clinical diagnosis. It cannot be made by any one simple test, and that volume status is depicted on the Guyton analysis by your venous return curve. Whereas volume responsiveness is actually kind of uncoupled from volume status, and volume responsiveness is defined by your Frank-Starling curve, or your cardiac function curve, and that is whether or not you're on the ascending portion. From Chapter 6, it should be quite clear that right atrial pressure is not synonymous with volume status, and it has a poor correlation with volume responsiveness. Transesophageal assessment of the superior vena cava collapse during mechanical inspiration is a good predictor of volume responsiveness, whereas subcostal assessment of the inferior vena cava dilation during mechanical inspiration is also a good predictor of volume responsiveness. And again, this SVC collapse and IVC dilation were derived in patients who were heavily sedated, potentially paralyzed, receiving relatively high tidal volume ventilation. And again, the stress on the cardiovascular system in these patients is the change in intrathoracic pressure, much like it was for pulse pressure variation. And that when you deviate from these initial patients in which this was derived, the sensitivity and specificity of these results becomes degraded. Okay. By contrast, inspiratory collapse of the inferior vena cava is loosely correlated with right atrial pressure, and it's correlated neither with volume status, that is absolute volume status, nor volume responsiveness. And this may ruffle some feathers because I see people walking around and performing this assessment all the time. I hope after this talk you realize why that's not necessarily the case. The seemingly paradoxical responses of the superior and inferior vena cava may be understood in light of their anatomy and physiology. So let's talk first about the superior vena cava. This is something I've actually never seen done because it requires clearly a transesophageal echo probe. But I think it's worth talking about because it's kind of a nice intro to the physiology of IVC collapse and dilation. So when a patient is fully adapted with a ventilator, mechanical inspiration will facilitate collapse of the SVC. The collapse of a vascular structure will occur when the transmural pressure of that vessel is reduced. Okay, the transmural pressure, or the across the wall pressure, is the pressure within the vessel less the ambient or surrounding pressure. So if the pressure around the vessel goes much higher than the pressure in the vessel, the transmural pressure is decreased, and the tendency of that vascular structure will be to collapse. In terms of the superior vena cava, this transmural pressure is the right atrial pressure less the pleural pressure, or the intrathoracic pressure. Recall from Chapter 6 that the relationship between the vena cava transmural pressure and its vascular diameter is curvilinear. So you can apply this to the IVC or the SVC, and it's essentially the same physiology. In the superior vena cava diameter, related to its transmural pressure, again, its transmural pressure is the central venous pressure, or the right atrial pressure. That's the pressure on the inside minus the pressure on the outside, which is your pleural pressure or intrathoracic pressure. So what's happening during a mechanical inspiration? Why would the right atrial pressure change relative to the pleural pressure? Wouldn't they just change in unison? It's a common misconception. But during a mechanical inspiration, the increase in the right atrial pressure, or the CVP, relative to the increase in the pleural pressure is decreased. So it's not worded terribly well, but I think I'll animate it fairly well. So the transmural pressure of the superior vena cava is therefore reduced. So the pressure that in the vessel, the CVP, is going up, but it is going up not as much as the pressure around it is going up. It's not as going up as much as the pleural pressure in the fully passive patient receiving mechanical ventilation. So if the transmural pressure is reduced, as I said, pleural pressure is going up higher or to a greater extent than the CVP, or the right atrial pressure. This is going to shift leftwards. The transmural pressure is going to decrease. Okay, and that's going to facilitate collapse. So if you're on this portion of your curve, you're not going to see very much collapse at all. So the patient, their SVC is on the flat portion of their pressure diameter relationship. This is taken to be a marker like the cardiac function curve as being preload non-responsive, and indeed that's what's been found. Patients whose IVCs don't collapse during mechanical inspiration, they are not fluid responsive. Okay, but if the patient is down here and you increase or you decrease the transmural pressure, that is, you increase the pleural pressure relative to the increase in right atrial pressure, well, they're going to have a much greater collapse. The superior vena cava diameter is going to go down to a much greater degree, and these patients have been shown to be preload responsiveness. So why does the CVP go up to a lesser extent than the pleural pressure during a passive mechanical breath? Well, this is kind of a cartoon that you may have seen multiple times in my lecture. I've modified it a little bit. This is your thoracic box. This is your mean systemic pressure going into the thorax. So this is you can sort of think of this as somewhat like the IVC going in. I want you to think of this bubble as the superior vena cava, okay? And then I want you to think of this outflow tract as being everything distal to the superior vena cava. So that would be the right atrium, the right ventricle, the pulmonary vascular bed, the left atrium, the left ventricle, the aorta. So that's essentially, all of that's packed into here. That's blood going out of the thorax. So blood's going in to the thorax, blood's coming out of the thorax, and at some point it's passing through the SVC if it's coming from the head and shoulders. So what happens with the mechanical breath? Pleural pressure goes up, right? Airway pressure goes up. Transpulmonary pressure goes up. The lungs press out against the chest wall, and that increases your pleural pressure. And you can see that if you were to measure, if you had a probe going into the pleural space, or if you use an esophageal pressure probe as surrogate, you'd see the pressure go up, and the intrathoracic pressure would go up. This pressure is then distributed to the SVC, so the SVC pressure also goes up. So if you had a pressure probe in the SVC that you might have with your triple lumen catheter, you'll see the pressure go up as well during a patient who's passive with a mechanical ventilator. But it would not go up. We don't ever measure this, so we don't see this. It doesn't go up as high as the increase in the pleural pressure. Well, why does it not go up as high as the increase in pleural pressure? Well, you shrink venous return, right? As this goes up, you decrease the gradient for venous return, so less blood comes into the SVC. And at the same time, the heart continues to pump blood out of the SVC. So this, the pressure in this space is actually lower than the pleural pressure because the blood that's in here is kind of being diminished from coming in, and at the same time there continues to be blood leaving the thorax. So while the SVC pressure is going up, it's not going up quite as much as the increase in pleural pressure. So then if you were to measure the pressure in the superior vena cava relative to the pleural pressure, the superior vena cava pressure would actually be going down relative to the pleural pressure, and that would facilitate collapse of the SVC during a mechanical breath. So while the pressure within the right atrium or the superior vena cava does increase relative to atmosphere, it is diminished relative to the increased pleural pressure, and that leads to collapse. And it doesn't go up nearly as much as the pleural pressure, primarily because of a reduction in the venous return, and at the same time cardiac function maintains blood flow out of the thorax. So your central venous blood flow is still being diminished while pleural pressure is increasing. So that can be graphically illustrated on this hybrid between the Guyton and Campbell analyses that you've seen ad nauseum at this point. So the application of volume or pressure via a ventilator to the trachea results in an increase in the central airway pressure, and that is depicted on the elastance curve of the respiratory system. So this curve is a summation. This curve here is a summation of the compliances of the lungs and the chest wall together. Okay, so that is the pressure you would measure at the proximal trachea off the ventilator. The increase in pleural pressure is a function, as we talked about, of tidal volume and chest wall compliance, and follows the chest wall compliance curve. So if this patient receiving the same mechanical breath, their airway pressure goes from there to there. This curve to the left here represents airway resistance. Intrathoracic pressure moves along the chest wall compliance curve, and pleural pressure increases to there. Doing the same breath now with the superimposed Guyton analysis. This here represents the superior vena cava trans-mural pressure. Okay, it's the intrathoracic pressure or the pleural pressure relative to the CVP. This is that trans-mural pressure we saw on the x-axis just a couple of slides ago. So you give the positive pressure breath, intrathoracic pressure or pleural pressure increases, but the SVC transmural pressure decreases, and that's because the intrathoracic pressure increases to a greater extent than the increase in the central venous or right atrial pressure. And the reason that this does not increase as much is, as you can see, it's a function of your venous return and cardiac function curve. So there's a decrease in your venous return, and at the same time cardiac function maintains blood flow out of the great veins in the thorax. So while the SVC, right atrial and right ventricular pressure do go up with the increase in pleural pressure, they do not go up as much because of simultaneous changes, reduction in venous return, and maintenance of cardiac output. And that's graphically represented there. So the RV function curve, as we just saw, shifts to the right with the pleural pressure, and this illustrates the decrease in right atrial pressure and superior vena cava transmural pressure. Again, this patient is passive with the ventilator. Okay. Well, what about the inferior vena cava with a mechanical breath? The physiology is a little bit muddied when assessing the inferior vena cava. The reason is that the ambient pressure of the inferior vena cava is no longer the pleural pressure, it's the abdominal pressure. Remember the IVC, there is really no intrathoracic IVC in humans. There are in dogs, but essentially as soon as the IVC crosses the diaphragm, it goes directly into the right atrium. So it's kind of a potential vessel, whereas the IVC that we're looking at with an ultrasound is actually intra-abdominal. This is less of a problem when a patient is heavily sedated and potentially paralyzed, as abdominal pressure increases consistently with each inspiration. And the change in abdominal pressure is a function of the change in abdominal volume with inspiration as the diaphragm descends, and abdominal compliance. Okay. Excuse me. Therefore, during a mechanical breath, the central venous pressure or right atrial pressure is increased relative to the increase in abdominal pressure. So now I've modified my diagram a little bit more. And so now you can sort of think of this as the inferior vena cava. This is your mean systemic pressure driving blood back to the right atrium. And then this is the outflow of the thorax. So this short space here from the right atrium to out of the thorax, this would represent everything in between. So that would be the right ventricle, pulmonary vascular bed, left atrium, left ventricle, aorta, everything right here, blood going out of the thorax. So during a mechanical breath, pleural pressure goes up. Remember, ventilator delivers volume to the airways. That increases your airway pressure. That pushes the lungs open. The lungs push against the chest wall in the passive patient. And that increases your pleural pressure as the lungs push out against the chest wall. We don't ever measure this, but this is what we would see. Because the right atrium is intrathoracic, it tracks up with the increase in intrathoracic or pleural pressure. And this is what we would see, and we see this frequently when we put a triple lumen in or a pulmonary artery catheter and we measure the increase in right atrial pressure. What we don't ever measure is the increase in pleural pressure, and if we did, we'd see that actually the increase in pressure of the right atrium is not quite as high as the increase in pleural pressure, and we talked about why that was in the previous slide. Okay. With the breath, there's also a descent of the diaphragm, and abdominal pressure goes up, but it goes up not quite as much as the increase in right atrial pressure, because less of that intrathoracic pressure is distributed to the abdomen. Simultaneously, there's a decrease in venous return because of the increase in upstream pressure while abdominal pressure is increasing. So what does that do? Well, that increases the pressure in the right atrium and very distal IVC relative to abdominal pressure. So remember the IVC, as soon as it crosses the diaphragm, it's essentially in the right atrium. So as the right atrium goes up, the pressure in the IVC goes up relative to the increase in abdominal pressure. So this increase in right atrial pressure relative to the increase in abdominal pressure, this creates a bit of a distending pressure, and the IVC actually dilates during a mechanical inspiration in the patient who's fully passive and not generating any negative intrathoracic pressure. So what was found is that actually IVC dilation with mechanical inspiration is a good predictor of volume responsiveness. It's the same physiology. Now your transmural pressure is the right atrial pressure less your abdominal pressure. So during the mechanical inspiration, the increase in CVP relative to the increase in abdominal pressure is increased. So the transmural pressure of the inferior vena cava is actually increased in the fully passive patient. So now we're moving rightwards on the transmural pressure graph. So your CVP, the right atrial pressure, is going up relative to the increase in abdominal pressure in the fully passive patient. So if the patient is on this portion of the IVC, IVC diameter transmural pressure relationship, there's going to be minimal dilation, and this patient is not going to be preload responsive. Whereas if the patient does have a large increase in IVC diameter with mechanical inspiration, then this patient will have dilation, and this patient will be judged to be preload responsive, and indeed that's what's been seen. So in the studies of both SVC collapse and IVC dilation during mechanical ventilation, there were consistent changes in intrathoracic pressure. Again, like pulse pressure variation, the reason is that the patients were sedated and paralyzed and receiving a constant volume-limited mode of mechanical ventilation. Thus, for reasons similar to pulse pressure and stroke volume variation described in the previous sections of this chapter, the parameters derived for volume responsiveness are context-specific. Deviation from the physiological constraints under which the diagnostic parameters were defined will alter said diagnostic parameters. So imagine a patient who is heavily sedated and fully passive with the ventilator. The patient has both a transesophageal and transthoracic assessment of his vena cava. Consider that the SVC fails to collapse and the IVC fails to dilate during inspiration. Both parameters therefore suggest a lack of volume responsiveness. So let's, for argument's sake, say this patient is not volume responsive based on this data. Now imagine the patient is lightened from sedation and begins to generate respiratory efforts, both inspiratory and expiratory. So now consider the vena cava pressure-volume relationship. During the passive mechanical inspiration, the increase in CVP relative to the increase in the abdominal pressure is increased. This patient is not volume responsive. Okay, so that's what I just explained in this patient. The CVP is going up with the mechanical inspiration. The abdominal pressure is going up to a lesser extent. There's an increase in the trans-mural pressure, but the patient does not have a change in their inferior vena cava diameter. So this patient is volume not responsive. Now his sedation is lightened and the patient begins spontaneous inspiration. So now we've changed the physiological context and you can no longer apply the diagnostic parameters that were derived from the patient who was completely paralyzed and sedated with the ventilator to this patient who's generating inspiratory and expiratory efforts. So this patient now who's dropping their inspiration or dropping their intrathoracic pressure with inspiration is now going to drop their CVP with inspiration and increase their abdominal pressure as they contract the diaphragm and compress the abdominal contents. Their abdominal pressure is going to go up. So pressure in the vessel going down, pressure outside the vessel going up, and now transmural pressure is going down. So this patient, depending on really multiple factors, one of them being how active they are in inspiring, this patient could have a pretty significant collapse in their IVC. But what I just told you was this patient is not volume responsive. This new physiology is simply a function of him changing his intrathoracic pressure and can really tell you nothing about whether the patient is volume responsive or not. So that leads us into the question of what exactly does collapse of the IVC during a spontaneous inspiratory effort tell us? Well, all it really tells you is that the CVP during inspiration or the right atrial pressure has dipped below the ambient abdominal pressure. And you kind of have to work backwards and figure out what that means. So there is a relationship between the central venous pressure and IVC collapse during inspiration, but this relationship is far from direct. Recall from Chapter 6 that CVP does not tell you a patient's volume status. So even though there's a loose relationship between CVP and IVC collapse, you cannot infer a patient's volume status from collapse of the IVC. Nor does a patient's CVP really adequately tell you if the patient is volume responsive. Remember, to know if you're volume responsive or not, you have to know if you're on the ascending portion of your Starling curve. And collapse of the IVC really doesn't tell you that information at all. All collapse of the IVC is telling you is that right atrial pressure is dropping below abdominal pressure. And there's a zillion different reasons why that can happen. physiologically it might be loosely related to being volume responsive or not, but it's far from definitive. So this is your collapsing IVC that you may see with your bedside ultrasound. So again, that tells you that either or right atrial pressure has fallen, which is really a function of these three things: the decrease in pleural pressure, and that's going to be dependent upon, how actively the patient inspires. The change in the venous return curve, that occurs with inspiration. So as you may have seen in Chapter 3 and Chapter 4, as you inspire, the slope and the shape of the venous return curves will change. And also as you inspire, the change in the right ventricular cardiac function curve, because it's really the triangulation of all three of these effects that's determining where your end inspiratory right atrial pressure is. It's how far that cardiac function, right ventricular cardiac function curve is dragged leftwards relative to your venous return curve, but it's also dependent on how the venous return curve itself is changed by inspiration, and how the cardiac function curve itself is changed with inspiration. So all of those simultaneously changing events determine the degree of your right atrial pressure drop. Okay, and that is only one determinant of what's causing IVC collapse. There's also the fact that abdominal pressure is increasing. So that's a function of the change by the change in abdominal volume, and that can be affected by actually how you inspire. If you breathe with your diaphragm versus breathe with your intercostal muscles, you will change your abdominal volume to different degrees, cause differing changes in your abdominal pressure, and therefore differing degrees of IVC collapse. And indeed, in healthy volunteers, if you teach them to breathe with their diaphragm versus teach them to breathe with their intercostals, you can have them collapse or not collapse their IVC, and it has absolutely nothing to do with anything. It has nothing to do with their right atrial pressure, certainly has nothing to do with their volume status, has nothing to do with volume responsiveness. And so the change in abdominal volume and also change in abdominal compliance. So, I had a patient who had massive ascites in the ICU, and he had terrible aortic stenosis, and the team was doing serial IVC assessments to see if the patient needed fluid or not, and I was just like gonna lose it. The guy kept having IVC collapse because he had massive ascites, and every time he would inspire so based on this physiology, a rough correlation between right atrial pressure and IVC collapse has been determined in healthy patients without pre-existing heart disease, abdominal abnormalities, and with calm inspiratory efforts. So let me say this again. There is a relationship between IVC collapse and right atrial pressure. Period. Does right atrial pressure tell you your volume status? No. Go back to Chapter 6. Does right atrial pressure tell you whether you're volume responsive? No. Go back through this chapter again. This is all that this physiology can tell you. This physiology has also been exploited to show that IVC collapse can be used to track changes in right atrial pressure in patients undergoing dialysis. It cannot determine your absolute volume status, nor is it adequate at predicting volume responsiveness. It certainly can be used to track changes in volume status, just like tracking a CVP would. If you're a patient undergoing dialysis and you come in with a CVP of 20, part of that CVP of 20 is determined by your high volume status. If you're interested in what the other factors in determining your CVP are, well, you should go back to Chapter 6, but it's determined by the intersection of your venous return, which is in and of itself partially determined by your volume status, but also your cardiac function curve. So if you take that patient and you dialyze them over a period of time and you drop their volume, well, yeah, their CVP is going to drop because you're dropping their volume status and you're shifting their venous return curve leftwards, and you're assuming that there's no dynamic changes in their cardiac function curve that's occurring simultaneously. So let's talk about this pictorially. So in healthy volunteers with a normal inspiratory effort, an IVC collapse of greater than 50% is an accurate surrogate for a CVP of less than 10. So this is your measured CVP here. It's slightly, this is 0. This is subatmospheric. This is above atmospheric. So this portion of your venous return curve will demonstrate when you start to see IVC collapse, and that's when the pressure within the great vein drops below atmospheric pressure or drops below your abdominal pressure. We're assuming abdominal pressure is going to be roughly equal to atmospheric pressure. And again, in patients with massive ascites or massive obesity, that just doesn't hold true. But for argument's sake, this is the patients in which this physiology was derived, and that's how we have to understand this. So this patient inspires normally, okay? Their intrathoracic pressure will track from here to here. This distance from here to here represents the drop in intrathoracic pressure. So that's one of the determinants. And then the other determinants are the shape of the venous return curve, okay? Remember, the shape and position of the venous return curve is dependent upon your mean systemic filling pressure, which is determined by your stressed volume, which is determined by your volume status. It's also determined by your venous capacitance. The slope of this curve is also determined by the resistance to venous return. So that's determinant number 2. And then the third determinant is actually the shape and slope of your right ventricular cardiac function curve. And as we talked about in Chapter 2, that's determined by multiple variables: your diastolic properties, your afterload properties, your valvular properties, your contractile state. Even the rate and rhythm of your heart rate can determine the shape and slope of this curve. So all of these things are actually all co-conspiring to determine your right atrial pressure at any given time. So this is the physiology that you see. Again, these numbers don't necessarily correlate with what I'm depicting here. It's just for illustrative purposes. That is, the right atrial pressure drops here, again, as a function of the intersection of the venous return cardiac function and drop in intrathoracic pressure, and abdominal pressure increases. You have an increase in blood flow, and then you start to have collapse of that IVC that you see. It's this fluttering effect, and that's what causes this plateau in maximal venous return. Okay, so that's what you see. If I were to take that healthy volunteer and give them a few liters of crystalloid, increase their stressed volume, therefore increase their, quote, volume status, therefore increase their right atrial pressure, their CVP, and then tell them to take the exact same make the exact same inspiratory effort, and they just kind of barely start encroaching on this Starling resistor physiology, you might see a little bit of collapse or not quite as much collapse, and this is an adequate surrogate for having a higher CVP, and the physiology makes sense. You might get less of a collapse, as I've illustrated there. Okay, so as I mentioned, note that the inspiratory value of the right atrial pressure is affected by primarily these 3 things: the degree of drop in intrathoracic pressure, and again, that's going to be determined by your pulmonary elastic properties, your pulmonary airway resistive properties, okay? The change in the venous return curve, and again, that venous return curve is affected by multiple variables, one of which is your volume status, okay? And the cardiac function curve itself, determined by multiple variables, one of which being your volume responsiveness, but it's impossible to predict. Okay, so let's go through that dialysis patient analogy again. Consider the following dialysis patient with a normal cardiac function curve and normal consistent inspiratory efforts and without elevated intra-abdominal pressure. So we'll say that this is a high intravascular volume. Their venous return curve is shifted way out to the right. Okay, so they've got a relatively high right atrial pressure. You tell them to inspire. They do. No collapse. You don't hit that Starling resistor portion. So this patient comes in, you say, okay, the lack of collapse of the IVC suggests that they have a high CVP, and you're correct. They have a high CVP, and why is their CVP high? Well, you're assuming they've got normal cardiac function, and it's probably because they haven't been dialyzed in a few days, and they come in all puffy. It's not really a diagnostic conundrum. You then proceed with dialysis, and the patient moves to euvolemia by shift, and that's depicted by the shift in their venous return curve to the left. And you tell this patient, take the same inspiratory breath. And they do. And now, oh boy, you get IVC collapse as you hit that Starling resistor physiology. The great veins begin to collapse as they enter the thorax. Okay, and again, this makes sense because, because there is a relationship between your right atrial pressure and IVC collapse, assuming abdominal pressure is essentially normal, that as you preload reduce somebody or drop their volume status with dialysis, that their CVP will drop. Okay, let's say this patient stays on board or stays on dialysis a little bit too long and starts getting a little bit hypovolemic. Okay, you've shifted their venous return curve way to the left. Now you tell them to take the same breath. Well, they certainly have IVC collapse now, and this all jives physiologically. Now I want you to consider a very similar patient. Everything about this patient is exactly the same, but this patient, a little bit of a hypertensive heart. Maybe the patient actually comes in with slow AFib, rate-controlled AFib. Maybe they're on a beta blocker. Maybe their tricuspid valve is not so competent. Maybe their lungs are a little bit fluid overloaded and they've got some high right ventricular afterload for some mild hypoxemia. Maybe this patient has some uremic pulmonary arterial hypertension. I mean, you pick your poison, but whatever the reason is, this cardiac function curve is shifted down and to the right. And let's just pretend this patient has the same 3 volume statuses, stati. Okay, for this, and then you tell this patient make the same inspiratory effort. At all 3 volume states, you may not actually see any collapse of the IVC. Well, what does that tell you? Ask yourself, what does that tell you? Okay. In all 3 states, beginning of dialysis, middle of dialysis, or hypervolemia, euvolemia, hypovolemia, no collapse, no collapse. Maybe you might start to see a little bit of collapse, but just say for argument's sake, no collapse. Is this patient, can this lack of collapse, does it tell you the patient's hypervolemic? Does it tell you the patient's not volume responsive? Does it tell you that they are volume responsive? It's simply a function of the reduction in their cardiac properties that's causing this physiology to be seen. And again, this graphic simplifies things somewhat, as the active inspiration can change the slope of both the cardiac function and venous return curves as well. So during a deep inspiration, just to illustrate that, during a deep inspiration, as you collapse, as the diaphragm descends to a great degree, you actually tend to shift the mean systemic pressure somewhat rightwards. But if you collapse the IVC during a profound inspiratory effort, you may actually increase the resistance to venous return, and you may actually then see IVC collapse in this patient. So this is the same patient with the diminished cardiovascular function who is not fluid responsive because they're very close, if not on the plateau of their cardiac function curve. And because of an excessive inspiratory effort, you now see IVC collapse. Well, does that tell you this patient's hypovolemic? Well, I've tried to illustrate it such that this is actually the euvolemic curve. Okay. And then with the deep inspiratory effort, you now see IVC collapse. So this patient is euvolemic, volume non-responsive, but you're seeing IVC collapse as a function of the deep negative inspiratory effort and the concomitant change in the venous return curve as the diaphragm descends. And so if you saw this patient's IVC collapse, giving them fluid actually be the wrong thing to do. And I've kind of talked about this a little bit already, but inferior vena cava and PEEP, this totally degrades the physiology of IVC collapse. And I mean, this is essentially every patient in the ICU is on some degree of PEEP on the ventilator, and I see them just getting this serial IVC ultrasounds, and everyone's IVC is collapsing, even these patients with EF of 5% and massive ascites and anasarca and chest wall edema, and they're cool and clamped down, and their they've got a PA catheter and their cardiac index is 1, and they're getting an IVC assessment and it's collapsing, so that means they need fluid. So please stop. I'm just begging you. The application of PEEP significantly alters the venous return curve, as we saw a number of slides ago, and therefore changes the physiology of IVC collapse as compared to healthy adults breathing spontaneously. The IVC collapses when it's intravascular. The pressure within the vessel falls below abdominal pressure. In normal adults, this typically occurs near atmospheric pressure because, as I mentioned before, end expiratory abdominal pressure is roughly atmospheric, and end expiratory intrathoracic pressure is slightly below atmospheric pressure. So the collapse or the pinching effect tends to occur right around atmospheric pressure. But PEEP changes that significantly. PEEP pressurizes the thorax, and it also pressurizes the abdomen. And this increased ambient pressure makes IVC collapse more likely. So if the patient has PEEP applied and the patient is making inspiratory efforts, the collapse of the IVC may occur at a much higher pressure than would be anticipated in a patient without PEEP. So if the clinician is using IVC collapse as a surrogate for volume responsiveness, editorial, then the clinician may be doing the patient a significant disservice. So let's take a look at IVC collapse. So let's say this patient is volume non-responsive. So I'm going to, if I increase their preload, you might get a little bit increase in cardiac output, but not significant. So actually this is a patient I do not want a fluid load based on this initial physiologic state. Depressed cardiac function, very near the plateau, is just what I said. So what happens when I apply PEEP? Well, it changes the venous return curve, as we've seen. It shifts the cardiac function curve rightward as a function of the increase in intrathoracic pressure. It shifts the venous return curve rightward by increasing the mean systemic filling pressure, and then it increases this P crit, which is the critical collapsing pressure. And so instead of collapsing at atmospheric pressure, it's now maybe collapsing at, pick a number, 3, 4, 5, 6 centimeters or millimeters of mercury. Okay, so it's making IVC collapse much more likely. So remember, the baseline state of this patient is volume non-responsive. This is a patient you do not want to give fluid to. This patient's on the ventilator. The patient triggers a breath. IVC collapse occurs. Must give fluids. No, that's not what you do. I just want to really drive home the point that IVC collapse does not equal volume status. IVC collapse does not equal volume responsiveness. IVC collapse equals right atrial pressure dropping below abdominal pressure. And the drop, you have to interpret both of those changes in light of the patient's clinical state. If they're have massive ascites and they're generating huge inspiratory efforts, well then you probably need to disregard that IVC collapse. If the patient is on 15 of PEEP and they're triggering, their own inspiratory efforts, I don't know what that collapse means. It could mean their right atrial pressure is low and they're hypovolemic, or it could mean that they're hypervolemic and volume non-responsive, and they're just, their maximal venous return is being decreased so significantly by pressurization by PEEP that you're seeing IVC collapse because of that. It's just, you have to turn your brains on when you're evaluating these patients. So that's what I want to say about assessment of the vena cava in terms of SVC collapse and IVC dilation as being adequate markers of fluid responsiveness in a very select patient population. And then in terms of spontaneous inspiration and IVC collapse, you really have to be very cautious about what that means. And what's even more frightening is I'm seeing papers in the literature that's looking at IVC collapsibility in patients who are mechanically ventilated and triggering their own breath on various amounts of PEEP, and they're disregarding IVC dilation during mechanical inspiration. In fact, in the results or in the methods, it'll say something like, the change in diameter of the IVC is complicated or difficult to predict in patients who are mechanically ventilated. Therefore, we assessed only collapsibility, and they didn't really take into consideration when that collapse was occurring, whether it was occurring during inspiration or expiration. And then they were using that as a marker of fluid status, and then their gold standard for fluid status was CVP. And it's just like, it's just this, incredibly large, confounded physiologic reasoning that's just leading to further confusion and potential, disservices to patients in the ICU. So, use your physiology responsibly. That's all I'm going to say. One more section to go, ladies and gentlemen.